So this morning I'm going to try and give you an outline of what we do and what you should try and do in terms of imaging stroke. And it'll involve a couple of main headings. So what is our job in, as a radiologist in trying to image stroke? What are the causes of strokes that we can try and image and determine for the neurologist? And then there'll be a section discussing the ischemic penumbra and some of the trials that you probably have heard of and know about. I'll outline some of those very briefly, particularly the trials involving TPA, which is FDA approved, and then the non-FDA approved thrombolytics like desmoterplase. And then assessing the risk of hemorrhage and complications from stroke therapy, and then lastly some future developments in stroke. How many people out there do perfusion MR for stroke in their practice? Can you put your hand up? Okay, how many people do CT perfusion for stroke? Okay, so how many people try and image the penumbra when they're trying to work up a stroke patient? Okay, how many people think they know what the penumbra is? Okay, so no one put their hand up. So that's, the holy grail for stroke imaging in the last few years has been trying to image the so-called penumbra. And in a sense, initially a lot of the work was done at the Mass General, with the Mass General group. And initially there was a penumbra that was seen between the diffusion and perfusion weighted imaging mismatch. And then later on when CT came along, people tried to find a penumbra with a different CT perfusion maps. So if you're using MR imaging, it's essentially the mismatch between the diffusion weighted image and a CBF or mean transit time map. And the diffusion weighted image is felt to be the good core of the infarct. So any mismatch between the perfusion, either CBF or mean transit time, and the diffusion abnormality is felt to be tissue at risk. So this was the kind of early definition of the penumbra. When people started doing a lot of CT perfusion, some people noticed that there was a mismatch between the mean transit time and then the blood volume and the blood flow map. So this is the correlate in terms of CT perfusion. And if you were to see this mismatch, then there is potentially tissue at risk. Now, a lot of this, we know, and a lot of what I'm going to talk about this morning, you'll know, but I'm going to give you some take-home messages. And one of the first take-home messages that you should go away from this is that really the penumbra is a very controversial issue right now. A lot of people are trying to image it, people are trying to define it using different metrics, and right now, my sense is there's no real good definition of the penumbra. Having said that, we already have a penumbra. Forget about all the perfusion, diffusion, and whatever else. The only penumbra you need to know is that if a person comes to the ER with the clinical features of a stroke, that is your clinical penumbra. You know that the patient has had a stroke, okay? And almost everyone in this room will probably do a non-contrast CT to look at what the stroke is, whether there's hemorrhage. So in other words, what I'm trying to tell you is that forget about the penumbra, forget about the diffusion, perfusion mismatch. I think there's a lot of, still a lot of controversy about that. Essentially, all we need to know is that if the patient comes in with hemiparesis, with clinical findings of a stroke, you do a CT. If the CT is normal, or if you see a small infarct, then this patient is a candidate for TPA. So this is a potential candidate for thrombolysis within the first 3 hours, potentially up to 6 hours in some studies. If obviously on a non-contrast CT you see hemorrhage, then the patient is not a candidate for TPA. And if there is a huge infarct, then again, there is a propensity for hemorrhaging. So again, this patient is not a candidate for TPA. Obviously, if there's another diagnosis, then you take another pathway. So this is really the gist of my talk this morning. Non-contrast CT, triage the patient. If there's hemorrhage or large infarct, no TPA. Okay, I can probably finish there now and go home, but I have to fill in another 35 minutes. So the rest of the talk, we're going to talk about some of these other headings. So how do we make a rapid diagnosis? What are some of the other findings of stroke, acute stroke that you probably should already know, so we're going to review that. Our first job is to look at the non-contrast CT, make sure that there's no acute hemorrhage. And sometimes it can be subtle, sometimes it can be very prominent like this, so that's easy. And then see if there is an underlying mass. Often it's difficult on CT, but sometimes we can see an associated mass or maybe a small AVM or a nidus. And then we'll always at this institution do CTA and CTP, and I'll go over the protocol for that later on. So just to review the findings and of acute ischemia. So on the left side, we see that there's some obscuration of the lentiform nucleus. There's loss of the insular ribbon sign. There's some effacement of the soul side. These are pretty subtle, but you've got to look very, very carefully. And I've missed some of these signs, particularly on Saturday mornings when we're on call on the weekend. The other sign is obviously the dense MCA sign, which again is a little easier to pick up, but obviously look for that as well very carefully. The progression of ischemia over the first couple of weeks or so, initially they have mass effect, sulcal effacement, loss of the gray-white, and then over the first week to 10 days there is progressively more mass effect, and then by 2 weeks you start seeing some resorption of that mass effect, and then by about 3 to 4 weeks you'll end up with what appears to be the final infarct size, which is seen as low density, involving gray and white matter of the brain. This is the second take-home message that I want you to take home with you. How many people are reading soft copy packs routinely now? Okay, how many people know about the stroke window or the narrow window for stroke? 3 or 4 people. Okay, so I think this is crucially important. And when we read head CTs, we have probably 4 windows that we would have preset on our PACS workstation. The first is the routine brain window. The second is a subdural window. The third is a bone window. And the fourth, and probably most important, is the stroke window, which I'll demonstrate to you how useful it is. And it was described probably almost 6 years ago by Mike Lev from MGH, and no one, particularly now that almost everyone is reading our PACS, is using it routinely. This is a patient, this is on a weekend when I was reading, when I was on call last year. This is a non-contrast hit CT, fairly normal looking. This is the next day. And you can see some subtle low density here in the right basal ganglionic region. So if you want to refer to this paper, it was in Radiology in 1999. Again, Mike Lev's group from MGH. You can see that on the normal brain window width of 80 Hounsfield units, centered at around 20 Hounsfield unit, you can see that it's still pretty hard to pick up the abnormality. When you narrow the window width on your PACS workstation down to about 8 Hounsfield unit and increase the center level to about 32 Hounsfield unit, you can see that the area of low density becomes much more apparent. And I would urge you, when you go back to your PACS system, to have a preset narrow brain window, and always look at that when you look at a CT brain. Or, obviously for queried stroke, you must always look at that. But I find this extremely useful. All residents, if they don't look at this, they'll get fired. But if you go back, it's very easy just to preset one of your PACS buttons on your PACS workstation so that you look at the narrow windows, and I will guarantee you that you will see many more strokes with this technique. This is the same patient looking at the CT perfusion abnormality, and you can see that there's extensive prolongation in the time to peak and the blood flow map here on CT perfusion. Let's briefly run through the time course for CT and MR abnormality. In the first 3 hours, you'll see that diffusion is clearly very sensitive, and we'll look at that. Within the first 5 or 6 hours, usually CT and routine conventional MRI, so T2 and FLAIR, are typically normal. Beyond 6 hours, you'll start seeing some abnormality on CT and T2 weighted imaging and FLAIR imaging. So the 2 numbers that you really should remember, I guess, within the first 3 hours, you're going to remember that CT is going to be normal, potentially, usually. Diffusion will be abnormal, and this is the time window that you need to consider for TPA. And sometimes some institutions are extending that now to 6 hours, where you will start seeing some minor abnormality on conventional MR imaging. Within the first few minutes, the diffusion will be abnormal, and within the first few seconds, in animal studies, you'll see abnormality with perfusion weighted imaging. Other signs that you want to look for on MR imaging are absence of a flow void, particularly when you look at the axial T2 weighted imaging. Look for arterial enhancement if you're giving GAD. And obviously, on T1 weighted imaging as well as T2, I'll show you, you'll see some very subtle cortical swelling and gyral effacement. And then certainly beyond 6 hours, you'll see hyperintensity on T2 weighted imaging. This is a patient that came in with left-sided weakness at 2 hours. Some people are doing some work now scanning at 3 Tesla versus 1 Tesla on the assumption that maybe at 3T we may be able to pick up some earlier strokes, potentially with diffusion weighted imaging. There are some papers which are demonstrating that. However, nothing's really been shown out there to really convince people that imaging strokes, diffusion at 3T is really that much better than 1.5 Tesla. So you can see on this patient, the CT, the flare, and the T2 weighted imaging is probably pretty normal looking at 2 hours. At 5 hours, you can see that, again, there is some early low density and maybe an insular ribbon sign on the CT. There is certainly some swelling involving the insular on flare and on T2, and there is some early effacement of the cell site on the T2 weighted imaging. Diffusion weighted imaging at 5 hours, you can see that there is diffusion restriction on the DWI at B1000, and here's the ADC map. Very important to look at the ADC map to exclude T2 shine through. If there is real diffusion restriction, there must always be low signal on the ADC map. And then at 2 days, you can see that there is now extension of the infarct on the diffusion, and here's the ADC map, and here's the abnormality on CT imaging. This is a interesting and important study from the Mass General group, and they reviewed 691 patients at Mass General in the first 12 hours of the stroke coming into the ER. And they compared the sensitivity and specificity of CT versus conventional MR and diffusion weighted imaging. You can see that the sensitivity and specificity using CT alone is pretty, certainly the sensitivity is pretty low, so 42%. Very good specificity if you find an abnormality. With MR, this is not including diffusion, so we're just with MR alone, you can see that the sensitivity is pretty good, 70%, very high specificity, but look what happens when you include diffusion weighted imaging. So you must always obviously do diffusion. The sensitivity is up to 94% with very high specificity. So you can see that if you're really wanting to exclude a stroke, then diffusion is really key. This is a slide lent to me by Howard Rowley, and really nicely demonstrating the time course for T2 abnormality, diffusion abnormality, and ADC abnormality. So as we mentioned, within the first 6 hours, you'll see that the T2 weighted imaging will be normal beyond 6 hours, and certainly by 24 hours, you'll see some swelling of the gyri. And then by 7 days, very marked abnormality on the T2. And then beyond that, you'll start seeing the T2 abnormality tailing off. On the diffusion weighted imaging, in the first few minutes, certainly the first hour, the DWI will increase in signal intensity and peak at about 3 or 4 days, and then by about a week, it'll start coming down in signal intensity. The ADC, which is really more sensitive, if you look at that very carefully, becomes very abnormal and drops very rapidly in the first 24 hours, and then really peaks at about 24 hours to 2 or 3 days, and then starts coming up. So by about a week, you'll start to see some normalization of the DWI abnormality. And then by 30 days, you'll see that on the ADC map, there is actually increased signal, and this is what we see as T2 shine through. So when you look at the DWI and the ADC, you will see some increase in signal in these areas, and this is really because the DWI has a very long TR and a very long T, so essentially it has very heavy T2 weighting, so you'll have some element of T2 signal abnormality seen as T2 shine through. Okay, so how is it useful then? If you were to look at this patient, you can see that there are 2 areas of abnormal T2 signal. And if you wanted to differentiate acute from chronic ischemia, clearly the area that's abnormal on DWI is going to be the acute ischemia, and the area that's more chronic has no abnormality on DWI. Here's an interesting patient with a middle cranial fossa, meningioma. You can see that the lesion's probably compressing and occluding the right MCA, but there is all this surrounding T2 signal abnormality posterior to the lesion. And the question is this patient having a stroke, or is this primarily edema affecting the adjacent temporal lobe? If you look at the DWI, you can see that there's substantial abnormal signal, diffusion restriction, which has corresponding low signal on the ADC map. And so this is in fact ischemic rather than vasogenic edema. There are some artifacts, however, with DWI early on when we were doing it. We're seeing some signal loss in the phase encode direction. However, a lot of this has been virtually eliminated now with echoplanar imaging. You will still see some susceptibility, particularly in the frequency encoding direction and lower in the skull base and in the setting of hemorrhage. So here you can see at the petrous apex, this linear high signal intensity, which is artifactual, so don't be fooled to think that this is ischemic. So we're all see this now, and particularly at the skull base, you see a lot of that. In the setting of hemorrhage can appear very high signal on DWI. And the last pitfall is bacterial abscess, because the pus is very thick and the diffusion is restricted. You'll see here the patient has ventriculitis with some pus within the ventricles, and so the pus demonstrates diffusion restriction, and there is some low signal correspondingly on the ADC map. As you treat the infection over a 2-3 week time course, you will see that there is progressive decrease in the diffusion and ADC abnormalities. So by about 2 or 3 weeks, you'll see that most of that diffusion restriction has resolved. Okay, so once we've done our job in excluding a hemorrhage and deciding that patient has a stroke either on CT or MR, our next job is to try and determine what the cause is for the stroke. And these little pie charts really outlines for you what the breakdown is for different causes of strokes. About 15% of strokes that cause hemorrhagic strokes. Most of these are intracerebral hemorrhages. Some of them are subarachnoid hemorrhages. 85% of them are ischemic, and this is broken down roughly into 4 quarters by embolic phenomenon from a cardiac source, atherosclerotic phenomenon, or small vessel lacuna disease, and then about 30% are unknown. So if you were able to determine what the initial cause is, then you can then triage the patient to appropriate therapy or appropriate further workup. So if it was a thrombotic arterial cause, then the patient is potentially a candidate for TPA or desmodoplase thrombolysis. If it's a venous thrombosis or a venous infarction cause, then consider heparin or aspirin. If it's an embolic phenomenon from a carotid source, then I think for most people, the standard workup is still carotid ultrasound and time-of-flight MRA. A lot of people are shifting over to contrast-enhanced MRA and or CTA these days, and we're starting to shift towards doing more and more CTA. If it's a cardiac source, then cardiac echo. And then there is this entity that the neurologists are aware of called, it's called Call-Fleming syndrome, and this is due to a dehydration phenomenon in the brain, and this is treated with hydration and positive fluid balance. Vascularity cause, obviously steroids, and small vessel ischemic disease treat the blood pressure. So you can very easily, even on a non-contrast CT, determine what the inherent cause is. If there is a dense MCA sign, then it's due to arterial thrombosis, and you can make that diagnosis without having to do a CTA or MRA. Here's a patient, again, scanned on our 3T with abnormality on DWI, diffusion restriction, with a corresponding area of low signal on the ADC map, in keeping with an acute infarct. Here's a time-of-flight MRA demonstrating occlusion to the MCA branches, again confirming that this is an acute MCA stroke. I think most of us are still doing as a workup for embolic phenomenon, a combination of ultrasound of the neck plus time-of-flight MRA. There is now a shift towards doing so-called more angiographic techniques, so contrast-enhanced MRA or contrast-enhanced CTA, and I'll show you how we can combine that, a CTA in particular, into your stroke protocol, so you're getting CTA information as well as non-contrast CT information and CT perfusion. I think in the future we'll see that more and more people heading towards a contrast-enhanced CTA approach, where not only do you get almost a true angiographic image of the carotid, whether the stenosis is mild, moderate, or severe, and as well as that characterize any calcification within the carotid regions. These images demonstrating very nice correlation between the CTA and the DSA. With some of the newer MRI techniques now, you'll see that in the next few years we'll also be able to do time-resolved MRA, and these are using parallel imaging techniques. You can get coverage of the entire neurovascular system from the arch up into the circle of Willis, and these are 1 second temporal resolution. So approaching what you're getting with DSA, those of you who are doing angiography, remember that about 1 a second or maybe 2 a second is the temporal resolution that you're getting for DSA. This is a circle of Willis MRA that's obtained using 5 cc's of contrast. So you can inject 5 cc's of GAD, obtain your 1 millimeter isotropic resolution MRA of the brain, as well as do your MR perfusion with the rest of the 15 cc's of GAD. So that's what we're doing now here as part of our time-resolved MRA and MR perfusion protocol. So 5 cc's for this time-resolved MRA, as well as 15 cc's for MR perfusion. Okay, just want to point out the importance of dissection. This is something that, if you miss, you could kill a patient, and I tell the residents, to always look at images for a dissection, because it's, the signs are usually fairly obvious, and it's important that you not miss it and look for it carefully. So dissection results from an intimal tear of the wall, and extracranial dissection usually involves the ICA, 2 centimeters or more distal to the bifurcation, and that's where you want to look more carefully for it. So it can either be traumatic or spontaneous. On T1 weighted imaging, you'll see that little crescent of intramural hematoma. On CTA, which I think is probably going to be a better test for dissection, you'll see some luminal narrowing, irregularity, and I think because again, this is probably more of a true angiographic technique, you'll probably see the double lumen sign more readily on a CTA than on a time of flight MRA. And then you'll see pseudoaneurysms as well. So just to refresh your memory, here's a T1 weighted sequence with non-fat saturation. See that crescent of intimal hematoma that you would see in the carotid with fat saturation. If you can get good fat sat on your magnet, do it with fat sat. You don't really need it if you don't have good fat sat. So you can see that crescent again in the carotid. On CTA, and this is some work that's ongoing now, we're finding that we're seeing things like pseudoaneurysms. Again, because you're injecting contrast into the vessel, you're actually seeing the pseudoaneurysms much more clearly than a time of flight MRA, where potentially the slow flow or the altered flow dynamics, you may not see the pseudoaneurysm. You see irregularities. So this patient has FMD as well, I think, on the CTA, which you don't really see on this somewhat poor quality time of flight MRA. And then the narrowing that you'll see on the CTA, can't really tell very clearly on a time of flight MRA. So I think more and more we're probably going to head more towards CTA for dissection. Okay, and spend a few minutes on this section, and this is some of the update stuff on what clinical trials are going on for thrombolytic therapy. And I guess we should know about this because some of us are probably involved with these trials and want to see what's going on with these trials. So this is an evolving area of imaging and interventional research. So as we mentioned at the start, the Penumbra is really the key that we're trying to image. However, the only thrombolytic agent that's FDA approved is TPA in the first 3 hours of onset of a stroke. Some of the other thrombolytic agents, there's desmoteplase being investigated with the DIAS and DDAS trials, and this is looking at a thrombolytic agent, taking it beyond 3 hours, up to 6 and 9 hours with intravenous desmoteplase. And then there are some other agents that you may read about, tecnitoplase, retiplase, which have longer half-lives, which potentially can even prolong your therapeutic window even further. And then there are some people working on oxygen therapy and hypertensive therapy to treat stroke. But as we had already mentioned at the start, if you take home with you the message that, stroke patients already have this clinical ischemic penumbra, and all you really need to do is a non-contrast CT, which is why there are these 2 major trials and a couple of other smaller ones going on, the EPITET and the DIFFUSE trials. And these 2 trials are really trying to determine whether this penumbra, because there's really no large multi-center trial. The EPITET trial is, I think, a 7-center trial, which is really trying to determine if the penumbra is worthwhile imaging, if the perfusion-diffusion mismatch can predict response to TPA, and whether we should be doing perfusion imaging and diffusion or CT perfusion to determine if the mismatch will guarantee a good response to thrombolysis. So if there's no mismatch, then clearly that, not good with thrombolysis. Under the inclusion criteria, if the diffusion abnormality is greater than 100 cc's, or if the perfusion mean transit time, and we'll go through some of these metrics, is longer than 8 seconds, then these patients are not included in the trial. So these 2 trials, the results are just starting to come through now, and I think we're starting to see some mixed results. So in the next couple of years, we'll really determine whether imaging the penumbra will be useful or not in directing thrombolytic therapy. This is a vampire bat, and the saliva of the vampire bat, this is a slide lent to me by Howard Rowley, has a very, very potent thrombolytic agent called desmoteplase. And this agent has high fibrin sensitivity, so it's now being looked at in a couple of trials, so the DS and the DDAS trial, where they're trying to prolong the therapeutic window to beyond 3 hours, up to 9 hours with intravenous it's not a place. And the results are fairly promising with this. I think that, the problem is trying to get that patient in within 3 hours, doing the CT perfusion, and then trying to treat the patient. So I think this is looking like a fairly promising agent. So just to review then, if you're wanting to image the penumbra, the mismatch between DWI and CBF and mean transit time maps. If you're doing CT perfusion, then the mismatch between the mean transit time and the CBV or CBF. And again, I want to reiterate that there's a lot of controversy about what people are using to image these two penumbras. And this is the triage that we spoke about earlier. What are the benefits of doing perfusion? If you're thinking about doing perfusion on top of your non-contrast CT, well, a lot of the time, as you'll see, and a lot of you will know, the non-contrast CT will be normal. But then, what really is going on? Is the patient really having a stroke, or is there really a large stroke that's occurring? So I think that doing perfusion, and we'll show you our protocol for CT perfusion and CTA, really demonstrates to you what the extent of tissue at risk is really going to be, and what the vascular distribution is. So I think, the feeling is that it does really enable more optimal selection of therapy. So you can see in this patient, 70-year-old male with hemiparesis, fairly normal looking non-contrast CT. If you look at the CT perfusion, you can see that the substantial abnormality involving the entire MCA territory here on the transit time, CBV and CBF maps. Similarly on perfusion MR, if you're to do that looking for the penumbra, here's the diffusion abnormality. And then the mean transit time map is clearly very substantial. So the white areas or the bright areas are clearly the areas that are at risk of ischemia. And if you were to look at the final infarct size, it's really somewhere in between the diffusion abnormality and that mean transit time abnormality. So just to show you diagrammatically, here's the core of the infarct. And the mean transit time map is usually somewhat larger than that. And then the final infarct size is somewhere in between that. So when you see that mismatch, that's the tissue that you're trying to salvage with thrombolytic therapy. If you're doing it with CT perfusion, again, this is very controversial. If you're trying to look for the penumbra between the mean transit time and either the CBV or CBF map. So again, the transit time is felt to be more of the core, and then the CBV or CBF is that in-between tissue at risk. So again, a patient here with a non-contrast CT, here's the abnormality on the CBV. On the mean transit time, there's a small area here with a corresponding larger area of transit time abnormality, and here's a follow-up somewhere in between the two maps. How do you do perfusion imaging? Here, we tend to inject 20 cc's of contrast using a fairly high temporal resolution, so 1 second acquisition. And what we do is plot the signal intensity curve. So we're using a T2 star technique over the first 60 seconds. So we inject probably about 10-15 seconds, and we plot the signal drop over time over the first 60 seconds in the first pass. So this would be the kind of curve that you would see for a normal part of the brain. If you had a stroke, a couple of things happens. You'll see prolongation in the time to peak. So the time from the initial injection to the peak of the bolus is delayed when you look at the signal intensity map, as well as that the transit time through the tissue of interest is also prolonged. And you'll see that the volume of the area under this curve is also increased. And that's probably because when you have a stroke, you'll get collaterals coming in from the periphery, and the blood volume is actually increased in the setting of an acute stroke. If you were to look at how we deconvolve and obtain the various parameters from the signal intensity curve, basically you would fit a change in relaxation time curve over time. And then the area under this curve essentially gives you the blood volume map. And then from that, you can determine a whole bunch of other metrics, which will help you determine what the CBF is. Just want to spend a second on this case, and this is where it can be useful sometimes, where the question is, are we dealing with a stroke, or are we dealing with a tumor or something else? Here's a patient who came into us, probably 10-day history of right-sided weakness. Here's a non-contrast CT. Here's a flare, T2. Post-contrast abnormality, diffusion by about 10 days to 2 weeks, it starts to normalize. So here's the ADC map. Just to check that everyone's still awake, put your hand up if you think this is a stroke. Put your hand up if you think this is a tumor. All right, so there are some people who are still asleep, so we're going to do this again. Everyone has to put their hand up once. Who thinks this is a stroke? Who thinks this is a tumor? Right, so the majority of people felt this was a tumor, and this was shown to all the neuro faculty here at NYU. and we had the same disagreement as to whether we're dealing with a stroke or a tumor. So we do some spectroscopy, and I show you this just for interest, but if you were to do spectroscopy, this is what you would see. If you look at just the individual spectrum, you would see increased in choline to creatine and decrease in NAA. But if you look at the metabolites within the area of abnormality, you can see that all the metabolites are actually reduced in this area of abnormal signal compared with the contralateral side. So even though, for those of you who do spectroscopy, the choline, the creatine is increased, when all the metabolites are reduced, it's telling you that there is a problem with the metabolism within this part of the brain. And it's probably ischemic rather than tumoral. So if you look at the total choline, comparing it with the other side, the choline is reduced, so we're dealing with a stroke. This is what you would see when you normalize the choline levels. So you can see that the choline level, when you normalize it to the contralateral side, you can see that all these little peaks here are much smaller than the other side. This is what you would see in the setting of a stroke. When you look at the perfusion, and this is where sometimes people get misled, if you just look at the blood volume, so this red curve is the area under the normal side, and you can see that when you look at the blood volume, so the area under the rest of these curves, it's actually increased. So some people would look at that and think, oh, the blood volume is increased, we're dealing with a tumor, and we've had cases sent to us from other institutions where people are misled, and we were initially misled too, when you look at the blood volume, which can be increased in the setting of an acute stroke. But if you look at the transit time, here's the transit time for the normal side, and when you look at the abnormal side, there's actually delay in the transit time in the left MCA, and you can also see that there's a very nice vascular distribution. So that's what you would see in the setting of an acute stroke. So that was in fact a stroke and not a tumor. So you can see how this can really help you with this pathology. Just to review briefly the central volume principle, which really ties in these different metrics, so CBF, CBV, and mean transit time, you can see that these are some normal values that you can take away with you that's in the literature. So blood flow is around 50 to 100 mils per 100 grams of tissue per minute. So in gray matter, it's roughly about twice that of white matter. Blood volume around 4. Mean transit time around 3 to 4, and the time to peak around 6. What happens when you have a stroke, you get occlusion of the primary parent vessels, so the MCA, for example. A whole bunch of collaterals will open up, so PL vessels through the circle of Willis. The mean transit time will increase as a result of that, and you'll get vasodilatation as well, which will also increase the blood volume. And this will continue to try and preserve the flow in the brain until you get a drop in the central perfusion pressure, and the end result of that is that the CBF will be reduced. I don't want to spend too much time on this, but this is just to show you some of the parameters of the blood flow measurements, from irreversible tissue injury to penumbral tissue injury to the penumbra to benign oligemia, and then normal is between 50 to 60 in the normal gray matter. If you were to use CT perfusion, there's some work now, and this is really for people who are interested in imaging stroke. All these metrics, as I've mentioned to you, are all very controversial. There was a paper in Stroke from June this year where they were looking at some newer metrics. One is called Tmax, which is the time between the start of the bolus to the peak of the bolus peak, and people are finding now that this may be a better measure of the penumbra or tissue that's at risk. So just be aware of that, and be aware that a lot of these parameters, time to peak, mean transit time, that you're deriving from your CT perfusion software are prone to a lot of issues and limitations when it comes to the post-processing. If you were to use diffusion-weighted imaging for your protocoling, this is a protocol that you can use, so you can do very quickly a T1-weighted, T2-weighted image, DWI, and a gradient echo sequence to look for blood products. And this, you can do in 5 or 6 minutes. You can inject contrast and do either a time resolved or potentially just a contrast enhanced GAD MRA to look at the entire neurovascular system, and then look at your perfusion, diffusion mismatch to select for therapy. And then obviously you can look carefully at your gradient echo and also the DWI to see if there's any blood products to determine whether the patient's at risk of hemorrhage or not. So if you were to use that to triage your stroke patients, if there's a large or substantial CBF and mean transit time abnormality, but the DWI is normal, patient is good candidate for thrombolysis. If the CBF and mean transit time is abnormal with a substantial DWI abnormality but less than 100 cc's, then again consider for thrombolysis. If there's very low blood flow or blood volume with an abnormal DWI, then there's substantial volume of dead brain, and so you don't want to give these patients thrombolysis because you're likely to have them bleed. So this is not a good patient for thrombolysis. And there are also a couple of other metrics. So if the ADC measurements are very low, with low CBF and very high transit time, then again, these are also not good candidates for TPA. I think more and more now people are heading towards using CTA and CT perfusion, and so this would be the protocol. Do a non-contrast CT, inject and do the CT perfusion and CTA, including the head and neck, and then decide for thrombolytic therapy and assess for risk. And this is generally the protocol that people are using and we're using here. There are obviously modifications depending on whether you're using a 4-slice or a 16-slice CT. Initially, people are injecting 90 to 120 cc's. You can probably get away with injecting less contrast now at 3 cc's a second. So a single injection of CT contrast, wait 25 seconds. You would then acquire 2 very quick acquisitions for the CT perfusion and then the CTA from skull base to vertex, and then a second acquisition encompassing the extracranial circulation of the neck. And if you had a 16-slice CT, you can actually do the whole lot now in the one scan time. So if you're doing the CTA and the CT perfusion, these are the parameters. And then for the neck, you want to do that second if you had a 4-slice, because you want to try and reduce a lot of the contrast in the subclavian vein so you don't get the streak artifact. So you would do that second after your CTA and your CT perfusion. These metrics are in a paper in AJR. Okay, so again, the triage you know about, non-contrast CT, this can all be done in less than 15 minutes. So this is a little old, so it shows 150 cc's of contrast. You can do it with 50 to 80 cc's now. Non-contrast CT, hemorrhage, end of exam, no hemorrhage, do CT perfusion and a CTA. Look at the CT and CT perfusion. All can be done fairly rapidly in less than 15 minutes. Lastly, how do you assess for hemorrhagic transformation? This is the subject of a lot of research in recent years because, obviously a patient with a stroke, if you don't do anything to the patient, they're probably going to do fairly well. But if you thrombolyze them and they die, then you're really not doing anyone a favor. So people are looking at what ADC thresholds are likely to predict hemorrhagic transformation. People think that if you have a fairly substantial ADC abnormality on diffusion-weighted imaging, then these patients are more likely to bleed, prior microbleeds, very high NIH stroke scale, and a very low CBF from MR perfusion or CT perfusion. And lastly, I just want to show you this. This is a sequence that I think is going to become a very important sequence for a number of clinical applications. In stroke, this is some work that's appearing both in the radiology and in the stroke literature. And you can see that this patient's had an MCA infarct, large infarct on diffusion. Here's the flare abnormality. Here's the gradient echo T2 star sequence that we would normally do looking for hemorrhage. And you really see no evidence of hemorrhage whatsoever. On this SWI, or susceptibility weighted imaging, you can see that there are particular hemorrhages within the brain. So this is a very sensitive T2 star image, which uses both magnitude and phase encoding information to give you information about susceptibility. So I think this is going to be very useful in predicting stroke. There are some people who are looking at permeability now, the mismatch between the permeability abnormality. This is a paper in AJR earlier this year, to predict the penumbra and also to predict hemorrhage. This is some work that we have been doing here with CT perfusion and MR perfusion. You can see that here's a patient which had a stroke in the right MCA. You can see the appropriate abnormality on CBV, CBF, and time to peak. You can see that there are a few foci of increased permeability seen on a CT perfusion map. And these areas actually later on went on to hemorrhage. So you can see that potentially these maps could be predictive of which patients are going to hemorrhage. Lastly, this is our 7 Tesla, which is going into CBI that actually went in over a year ago now. At 7 Tesla, you can actually image some of these very small vessels very elegantly, and potentially, if you were to image these patients with high resolution, high field imaging, you can see the vessels and even see which vessels are actually being occluded at high field.